jump into our talk. Again, we're going to be talking about research and treatment development for Canvas. So that is cerebellar ataxia neuropathy, vestibular areflexia syndrome. So if you need captions in order to engage better with today's session, you can turn them on at the bottom of your screen using the closed caption button. And if you'd like to connect with other community members who are listening to the same presentation that you are, please feel free to use the chat feature like we are now when we're sharing where we're coming from. However, if you have questions for our speaker, we ask that you put them in the Q&A window, which you can also find at the bottom of your screen. We're going to be pulling questions from the Q&A window during our question and answer period at the end. And if you put them in the chat, they might get lost. So please put your questions for our speaker in the Q&A window. We also will not be able to unmute anybody. So if you're using the raise hand function, unfortunately, we won't be able to call on you. We ask that you please type your questions in the chat. Type your questions in the Q&A window. There I go, contradicting myself. And with that, it is my pleasure to introduce our speaker today, Dr. Andrea Cortese. He is a neurologist and medical research council clinician scientist at the University College London in the United Kingdom and the University of Pavia in Italy. His research focuses on the discovery, modeling, and treatment of novel causes of ataxia and other neurogenetic diseases, with a particular interest in repeat expansion disorders and conditions that are caused by variations in non-coding DNA. And with that, I will pass the floor over to Dr. Cortese.
Thank you so much, Celeste, for the nice introduction. So a long introduction, but in reality, what we're really focusing on right now is today's topic. My research is currently focusing a lot in Canvas, and I wish, given the title I've been given, I would speak more about treatment and new curing treatments, but unfortunately, for the patient online, I'll anticipate that we're not quite there to keep expectation to where we are. But it's still very good that after, this was a completely unknown disease 4 years ago, but so many people around the world were affected, and at least for some of them, we are now able to give a molecular diagnosis or a genetic diagnosis and to inform them of how the disease behaves over time. How will impact families, if in any, and this being recessive, this is usually reassuring. And I'll speak a little bit more at the end of what we're doing in terms of research, where we're going, and how patients can engage in ongoing research studies. So I'll make this smaller so I don't. Perfect. I hope you can see the full screen, because I got a few things that pop up. But I'll since I've been involved in the gene identification, I'll tell you a little bit my story, which is really a story between me and patients and families I started to work on. So that would have not been possible without this collaboration and friendship with some of them. And so I'll speak about when we identified the gene, why was it so difficult in a way to identify for many years. I'll then tell you what what's our understanding now of the disease, how it presents, how it progresses, and what impacts on presentation and progression. So I will talk a little bit of prognostic factors, and really the main prognostic factor is the repeat size. I'll come back to that in a second. If there's anyone more from genetic, from a genetic background, from the labs, this is a quite cumbersome test. I know there's limited availability across the world, but particularly still in the US. So this is something that we're doing on a daily basis, this test, and I'll share some technicalities and mainly to also stress how we keep being really available to support clinicians or families who struggle to get this test. And I think that now the National Ataxia Foundation is very active as well and can help you and address it to the nearest center. And we never need we're always happy to jump in and help with challenging cases to achieve a molecular diagnosis. The mechanism, so the part of the talk which has to do with the mechanism, I'll share some slides. This is quite technical. I wouldn't say that there's a final understanding of what are the disease mechanisms. I'll tell you what we're doing, what some other people have been doing, and what are the ongoing studies in this field. So first of all, when it comes to ataxia, which is, is what National Ataxia Foundation deals, of course, many forms of ataxia are caused by disorder affecting the cerebellum. But it's true that the control of balance is more complex, and the cerebellum integrates messages coming from the periphery, and particularly from the sensory neurons. So sensation is key to keep your balance, as well as the vestibular system. And when the three cerebellum, sensory neuron, and vestibular labyrinth system are affected, we have this particular syndrome. And usually we say syndrome when we don't know what it is. And that was the case when the term was coined. C, cerebellar, A, ataxia, and neuropathy, VA, vestibular areflexia syndrome, which is really cerebellum, sensory neuron, vestibular. And these patients I was telling you have been, seen in clinics for many years, and some of the features have been described. We're looking at papers in the 90s. You had the excellent talk a couple of weeks ago, or last week actually, from our friends and colleagues, David from Australia, that really were key to define the clinical features. But as said, the diagnosis and the underlying genetics remained elusive for a long time. And particularly, there were people thinking this might not be genetic. It might be something acquired, degenerative. But when I started, myself working on genetics, I was puzzled by the number actually of patients that had a brother or a sister affected. And that was, as you quite rightly say, University of London, University of Pavia. I was working University of Pavia at that time, only there, and I saw these two patients, her in particular. The brother now has passed, unfortunately, for an unrelated condition. And I thought they had this identical condition. I hadn't heard about it. I looked it up and I said, that's what it is. She has vestibular, sensory, and cerebellar. So she must have CANVAS. And she told me, you know what? My brother has exactly the same. And I had to go travel to central Italy. I'm based in the north, Milan area. I went to see him, took DNA, which is what we do. And I convinced myself they have the same thing. This must be genetic. That is when I moved to the UK, moved to Queen Square, which is a very big hospital. And over the years, my colleagues there, Professor Holden, Professor Riley, they had collected families and many others over the years. And it was evident that something was going on. There was something genetics going on. But it was the time where people were looking very much at the coding DNA. So the parts of the DNA, which is 2% of our genome, which codes for protein. And they tried hard, but there was nothing really convincing. So with convincing, something which is shared by all the individuals from different families affected. So what we've done at that point, we took a traditional approach through linkage analysis. We combined all the families and we looked for a region shared across them, which works in case there's something which has happened remotely in time, and they all have it, and is frequent in the population in a way. And that's what we got. We had only one site in all the genome, which was shared by all the patients. And in this particular region, we had one gene, which is this replication factor complex subunit 1. Now, this is a protein which is involved in DNA replication, which allows the cells to divide, but also to repair DNA damage. And this is probably more relevant to neurons, which are terminally differentiated. They don't need to divide, but they do accumulate damage from the electrical activity, from the protein synthesis itself. So that's why this gene, as other genes involving DNA repair, can cause progressive neurodegenerative diseases. Having said that, still no mutation anywhere in the black part of the gene, the most important, coding for protein. But when we do sequence the whole gene, including the non-coding part, we saw that there was a particular region where instead of having a normal sequence, this is a normal, here is a normal sequence on the bottom, we saw something quite peculiar. We saw some reads, which is basically molecules that match your DNA, that came until this particular region, which is a repeated region. In normal condition, people have 4A, 1G, you know that the DNA is a series of letters, and there's usually 10 of them. So it's pretty short, and it's 4A's and 1G. But all patients, they had a change in the nucleotide sequence. Instead of 4A, 1G, 2A, 3G. But also importantly, there was no single read that was able to cross across this gap, okay, in this intron. And that's why we thought there might be some expansion of this repeated region and a change in the nucleotide sequence. So this is the underlying molecular defect. A change in the nucleotide sequence as any mutation and a further expansion. Now here it may become a bit technical, it's just confirmation, but this expansion is indeed pretty big. And we had to use this old school method, which is called Southern blotting. This is my Southern blotting. You see that, you know, it looks like handmade, it was. And these are the two chromosomes in a way, around that repeat in all controls, patient without that, so individual without the disease. And you see that in all patients, you have two larger stretches of DNA, which means the expansion is present on both chromosomes. We're looking at a recessive disease. But the only way to confirm this at that time was to go back again to a very old type of technology, Southern blotting, which is really not available in many centers. And what was interesting at that point is that apart from solving all these patients, and in our first paper, we had really, if I'm not mistaken, 150 patients that were in our clinic, and they were all sold from one day to the other after discovering this gene. But what is really also important is that the allele frequency of this expansion in the population is about 5%. An allele frequency of 5% means, to keep it simple, that 1 person out of 10 has the repeat expansion in one of the two alleles. You need 2 to have the disease. But the fact that 1 out of 10 people has the repeat expansion makes you understand how this disease will be increasingly recognized in the future, because it's probably still underdiagnosed. Not everyone knows about it, knows the feature, the progression is very slow. And the fact that 1 out of 10 people carries the expanded repeat makes a, guess that probably 1 out of 400, 1 out of 600 people is affected by this condition. And here is a video, and I know there's patients in the webinar, so they might recognize some of the difficulties that they have. The imbalance, the gait is broad-based, difficult to stand with the good feet together. Reflexes in this disease are retained as opposed to some other diseases, and this is the typical neurologic examination that we do. There are problems with the eyes. Many of you would know with this nystagmus, the eyes start shaking. It's difficult to follow something which moves smoothly. And then there's this key sign of the vestibular areflexia. So what happens when you turn the head, the eyes don't follow. You have to make a voluntary movement of the eyes to go back to the target. And we usually do it asking the patient to look straight at our nose. So this combination of sign when performed, of test when performed correctly, let's say they usually help us to suspect the disease. And when they're all abnormal, the diagnostic test is usually positive. But as said, this is a chronic disease. It progresses very slowly over time. And one of the things that we realized very early is that one of the most early presentation is the presence of a chronic cough. Now, we still don't know where it comes from. I know that for many patients, for many of you, might be particularly troublesome. It might be, and that's our current understanding, that has to do with the neuropathy itself, a neuropathy of the airways, so that the airways in a way lose innervation, and the nerves that are left triggers an erratic response, which ultimately it's triggering the cough. But this can precede by 10, 20, 30 years the onset of the ataxia. Ataxia, which starts rather at the age of 50, I would say, around at the same time, but often before that, there might be sensory symptoms like pins and needles in your feet, sensory loss, which is numbness, and sometimes pain, which is also particularly discomforting. Only later on, people will start having issues, and not really all of the patients, with speech. Generally, the speech remain understandable in most cases. With swallowing, swallowing is very important, and it could lead to complications, so it should be looked at. But again, incredibly difficulties, incredibly severe difficulties in swallowing are again rare. And then walking aids. So that if a patient is seen in clinic when they're around 40, there's just slightly unstable with a bit of sensory loss and cough, you see that you got another 20 years really almost before needing walking aids, and in some cases wheelchair, mainly for longer stretches and for extra safety to prevent falls, because swallowing difficulties with choking and lung infection, bad falls are what have really a negative impact on the prognosis. In some cases, we also observe dysautonomia, which might be difficulties with urines, sweating, bowel, and blood pressure. And this is something which is kind of variable. Some patients have it, some patients don't. Often not spontaneously reported, but if asked, it's just often is there. Not terribly severe, not terribly debilitating in most cases, but present. And when it comes to investigation, some of the neurologists, I'm speaking to an audience of mainly patients, I guess. So what I wanted to stress here is that, yes, a brain MRI is a good investigation, but still negative in many, because the difficulty with the cerebellum usually occur later in the diseases, are the ones that may affect your speech, the swallowing. But the sensory neuropathy, the problem with the sensory nerves, which also control the balance, are present earlier on. So that in one of the first series we described of 100 patients, all of them, when they did nerve conduction studies, had a sensory neuropathy. And many had vestibular impairment. So we think this is very early, and we personally think vestibular impairment can be tested very accurately and could be a good way of monitoring the disease over time, as might be the brain MRI. But we know that measuring the progression of the cerebellar atrophy is not straightforward. Anyway, going back to that series, you see that 60% of the patient had the 3 components of the disease, but some patient had only 2, and some patient had only a neuropathy. And that is what has pushed us in trying to identify more patients and see what's the full breadth of the phenotype, looking at patient with an isolated neuropathy. So we may be a little bit unbalanced, but also only sensory loss, pins and needles, or pain in the legs. And quite surprisingly, we discovered, we found that of patients with an idiopathic sensory neuropathy, so diseases of only the sensory nerve without weakness, 1 out of 3 was explained by this particular gene. And this is a very high percentage. And looking at other series, when someone has a sensory neuropathy plus cerebellar dysfunction, the percentage neared 60%. So this is an incredibly common disease when looking at the right phenotype. And the right phenotype is not an isolated cerebellar ataxia. We did look at, like, collaboratively with another group at like 50 patients with an isolated cerebellar ataxia, no neuropathy. Well, the disease, the prevalence of RFC1 expansion there was 0. So really, it will be, that's your neurologist's job when to suspect it, because if the examination and, collecting your story is accurate, then the diagnostic yield is particularly high. Right. And I think that it's fair that not just in our hands, there are now incredibly talented, good people and experienced research groups around the world that confirm that this is a common cause of adult onset ataxia and neuropathy. We also realized that some of these cases might have been misdiagnosed. One possible misdiagnosis is MSA, multiple system atrophy. Multiple system atrophy is very cerebellar. It progresses much faster, and there's usually no sensory neuropathy. Some people have probably found some coincidental presence of RFC1 expansion in MSA. And for those of you that I think may, browse in the web and, what's going to happen, there's been many reports. Those are scientific reports, so it's to be trusted. But what I wanted to stress that the core phenotype, this is a form of ataxia, which will affect your walking, a little bit the coordination of the upper limbs, potentially a little bit the sweep, the speech, sensation of your legs. But I would say that in most cases, really, cognition remains intact. There's been some cases where they've been associated with Parkinson's disease. I would say that, of course, that those are common neurodegenerative diseases, Parkinson and Alzheimer, dementia. But I would say I see many patients with this disease, and I would say that the occurrence of this complication is not common. So I wanted just to be a message to reassure you. This is a disease which is no disease is nice. There's no nice disease. They're all difficult, make your life harder, but this is not progressing like ALS, Parkinson, or dementia. In most cases, it will remain a disease affecting your balance. And there's still some variability, though. Cases that are more severe progress faster, some milder, just with the sensory neuropathy, with the complex phenotype. So we asked ourselves, how can we inform patients about how the disease is going to progress in them, in one single patient? So we realized that what really matters is the size of this repeat expansion. So this was a difficult study because we had to do that Southern blotting, that old school test in 400 patients, and we realized that the larger the expansion, the more early the onset of the phenotype, and this is particularly true for the smaller of the two alleles. So this is maybe a bit technical. Of course, you have two chromosomes. We have two chromosomes. One comes from mom, one comes from dad. To have the disease, you need a repeat expansion on both of them. Okay, but what really matters in terms of how the disease will progress, whether faster or slower, is the size in the one which is the smaller of the two. Okay, so, and that kind of tells us that probably is the one, or at least in another common recessive ataxia, Friedreich ataxia, has been interpreted as a further if you want, like a hit on that residual function provided by the smaller of the two alleles. So this is a bit technical, but the main message here is that knowing what's the repeat size might have a clinical implication and might be useful to predict how the disease progresses. Not only the age of onset is impacted by the repeat size, but also the phenotype. We saw the patient with isolated sensory neuropathy had a smaller repeat expansions, and also the time to the use of walking aid or developing dysarthria, speech difficulties, and swallowing difficulties was earlier, was anticipated in patients with larger repeats. The repeat is rather stable, which means if you have a repeat expansion, as you might know, you'll pass one or the other to your offspring. So they will all carry one repeat expansion, but one repeat, I remind you, is not enough to develop the disease. So they will all be carrier as one person out of 10 out there, but they will not develop the disease unless in the unlucky event your partner is that one out of 10 people in the general population that also has the repeat expansion. So generally, we rarely, very rarely see vertical transmission. So the disease affecting, you or someone in your family and then their offspring. This is quite rare. The repeat remains stable over time, and for the scientist on the call, it's also stable, mostly stable somatically, which means the repeat that we measure in blood is the same repeat size that we will measure in the affected brain tissue. Okay, and this is different from other diseases where we saw a striking increase of the size, which justify why some tissues are more affected than others in the cerebellum or in other parts of the central nervous system. Okay, so a last part for the geneticist on the call, if there's any. In most cases, as I said, the disease is caused by biallelic expansion, one expansion from dad, one expansion from mom. There are 1 out of 10 people has one expansion and has no disease, but we did notice the presence of people that have the exact full-blown canvas and only one repeat expansion. So if this is the case, the genetic test shouldn't stop because we have identified mutation in the coding region of the other allele, mainly mutation that stop the production of the protein on the other allele. This has been shown in multiple families and is something that geneticists and the lab should bear in mind when a patient has a typical canvas phenotype but only one repeat expansion. In these cases, we were able to show that there is a reduction of RFC1, both at transcript and at protein level, but this was not the case in patients with biallelic expansion. And this is and remain, I will say, very surprising because it's almost paradigmatic that recessive diseases like canvas are associated with reduced expression of the gene carrying the mutation. To add a little bit more complexity, yes, there is one predominant pathogenic allele, AAGGG, but over the last 4 years, ourselves, together with other colleagues, we identified some other pathogenic repeat motifs. And you can understand how it gets complex now to test them all for the labs. So there's pathogenic motifs that are more common in Asians. It's ACAGG. In the Maori population in Australia. And we identified in the UK as well some others that were previously unknown with like AGGGC, AGAGG. So you see that it's always 4 letters repeated many times, usually hundreds or thousands of times. And as you see, it's also quite peculiar that all of these pathogenic motifs, they have a high number of G's and C's in it. And I think this is really relevant, and then I go back to the rest, because it seems that these G's and C's, they form some structures in the DNA, which somehow trigger some downstream event, which may be hindering in some way, although we haven't been able to show you the transcription of the gene, or facilitating some other toxic effect of the repeat itself, of the repeat RNA or repeat peptides generated by the repeat. So this is, again, very technical. I don't think we have to spend too much time here, but it's interesting that all these motifs should be considered, or at least in a multi-step process, when we want really to achieve a molecular diagnosis. Clearly, AAGGG is the one that most diagnostic lab test, I think, is fine in most cases, but when a case has a definite syndrome compatible with Canvas and the genetic test is only partly positive, or we should just reconsider this rarer motive. And I think this rarer motive, it's an historical notice that they seem all to have a reason from an ancestral haplotype. And with ancestral haplotype, we mean part of the DNA which is inherited together. And we have that part of DNA, our parents, and going back by, hundreds or thousands of years, okay? And we were able to kind of date it, and it seems that the haplotype, so the stretch of DNA where the repeat is, which is here in red, dates back 50,000 years. Now, interestingly enough, 50,000 years is when the more recent, Homo sapiens have left Africa. And that's probably why this repeat expansion, so one expanded allele, has spread through continents, East Asia, and then to America. Obviously, America also from this side. And I think in America, you got more of our AAGGG repeat as opposed to the ACAGG, which is more common here in East Asia. But, it's an ancestral repeat expansion, part of an ancestral haplotype, and is common. So I don't know if there's anyone, from the labs on the call, but what we tend to do is to test. We still test it doing PCR, and so RP-PCR, repeat prime PCR, and flanking PCR. But then again, when we have only one expansion, but the case is typical, we recommend sequencing the gene, and in some cases, we do some extra work like Southern blotting, long-read sequencing, and optical genome mapping. So this is very technical, and it might not be of primary interest to patients, but it has been crucial to provide molecular diagnosis in some of them. Right, in terms of, going back to the title, models, I think there's not a huge amount of models out there, although there's very active and very skilled group that got interested in this disease, and they're producing excellent results. What I can share with you is that, as said, a bit in contrast with our general understanding of recessive repeats, RFC1 doesn't seem to be downregulated, because, if it was, then we could try to replace it, to just put more RFC1 in some way. It's never easy, particularly for big genes like RFC1, but there's no real evidence that the RFC1 is reduced, not in fibroblasts, but not also in affected brain tissue. And this is very different from Friedreich ataxia in blue, where we clearly see a reduction compared to control or Canvas. And that was RNA, this is protein. No change in the expression level, in cell lines, or postmortem brain. One of the possible mechanisms in repeat expansion is that this repeated RNA is forming some sticky structures which sequester other protein. And we didn't think they were clearly there. And this is in our hands. Some people think differently or have different, finding. And particularly in Asia, they seem to have found some of these RNA foci. They're not particularly themselves. They also tested the more common configuration. They were not it was less convincing, okay, less convincing, but potentially repeat RNA and repeat protein, and other people are working on this, may also be contributing, but we don't have a final answer of what is the underlying mechanism, and that is where really our development of targeted treatment is still stuck at the moment, okay. Obviously, in terms of management, I know that last week David has covered partly this. So if we don't have a specific treatment, what we can do is try to not make things even worse. And we're trying to do that by regularly follow up patients. I tend to see them every year to inform them about how to prevent falls and aspiration, which is when, you know, things go on the wrong way in the airways, and that can trigger a bad lung infection. Physiotherapy, occupational therapy, preserving ambulation and functional abilities is very important, and it does require, you know, keeping doing it. For the patient, and not everyone has it, neuropathic pain, so pins and needles which are with discomfort or proper electric type of shock or pains in the legs, or other form of discomfort that comes from the nerves. Well, there are a series of treatments which are partly effective. Gabapentin is something we try to give, and there are others. And the cough, I know, is extremely is troubling many of you, and I don't think there's an approved treatment for the cough. We're now working in close collaboration with some cough experts in London at King's College. They're trying a series of drugs, some also in trial, and patients respond differently. Some patients may have the decent response to pregabalin, which is also good for the neuropathic pain, some to morphine, although this should be prescribed just in selected cases for the obvious side effects. And if there's any gastroesophageal reflux, this should also be treated. But often this is not enough to reverse and improve completely the cough. So a little bit of what we're doing at the moment. We really want to try to do as much as possible for patients affected with this disease, and doing as much as possible means running multiple studies in parallel and doing them with other good teams and people around the world. And one thing that we need to figure out soon is how the disease progresses. And this is really where patients can be engaged, and often wants to be engaged in the early stages, because not everyone progresses in the same way. But it's key to know about this variability, because whenever from what we do in the lab, we'll have a molecule or something that we want to test. In order to design a trial, we need to know what to expect in terms of natural change of the disease over time. So we need outcome measure. So, and if you're interested, please touch base through the National Ataxia Foundation. You can write myself. We work with other people at Columbia, like Dr. Shengan. There's very good people in the US, and NAF can probably guide you towards the nearest center. We look at biomarkers. We do have a prominent genetic interest, and we think that, you know, the repeat size, yes, it does explain some of this variability in progression, age of onset, but there might be other genetic modifier, so that we're interested in looking at genetic modifier in other regions of your DNA, which may also guide treatment development. And then models. There's no one right model. We should use many of them, and many groups should use similar models, see what they find, and we compare results. We can look at cells which we differentiate in a dish into neurons. That's something that we're good at doing, but it's not exactly like having you. And in some cases, and you know, the disease is not meant to reduce the lifespan, which is a good thing. But in cases that, you know, for either because very old or just because they want to contribute for research, there's also a need for brain donation that has really enabled huge advancement in the field of Alzheimer's disease, Parkinson's disease. So for those of you interested, in 20 years time, 30 years time, let your neurologist know that you'd like to donate your brain or those cerebral ganglia for research, because this is really helpful. And I really hope we'll get to a cure before that time, but do bear it in mind. And then various models. Here is a mouse model, but we're working with flies, worms, and trying different things. So this is an ambitious plan. There's different groups involved. We work closely with Columbia University in this, and we'll hope that this will deliver soon. So in some conclusion, we RFC1 expansion is indeed a very common cause of ataxia and sensory neuropathy. We're getting to know the way the disease presents better. We get to know better what's the underlying genetics. Yes, there is a common biallelic repeat expansion, but it may be more complex than that. There's some variation in the repeat motif, which may matter. And there are some patients that have a coding mutation. So the gene should be sequenced. And this is a message to the diagnostic lab. I think it's fair to say that the mechanism ultimately why this biallelic repeat expansion leads to progressive neurodegeneration in such a selective way of the cerebellum and sensory neuron, the vestibular system, we still don't know, and we need to understand it in order to treat the disease. But I think the collaborative networks involving patient associations are the way forward. And we have multiple projects that if you're interested, please feel free to contact me or NAF. And a last slide to thank NAF for the invitation, my closer collaborator, really team member in London and Pavia, and all the patients and family, as well as the funders. And this is a key aspect as well, because there's almost no science possible without some support. And sometimes it's also family support. And thank you very much for joining, to all of you, this webinar.
Thank you for a fantastic presentation, Dr. Cortese. If you will end your screen share, then we will jump into the Q&A session.
Yep.
So our first question is a clarification. Could you elaborate on what is considered age of onset? Is that the start of the cough specifically, or of other symptoms?
Very good question. I didn't go into detail. We use the general, understanding in this case of neurological onset. So is any neurological symptom, cough excluded? Now, what I want to stress is that for some people, things like pins and needles in their feet go unnoticed for a very long time. So I think there's a bias and there's variability in the definition of this age of onset. We found that when we look at more definite outcome, like a clearly imbalance or speech difficulties, something that can be measured more clearly, the correlation between the repeat size and the onset of that specific, better measurable symptom is higher. And so that's why we think, that the repeat size is really relevant. But it's true. Age of neurological onset is many things, and there's a lot of recollection bias. Some people have less positive sensory symptoms, and they would not care that much about the numbness. They say, oh, yeah, it's been numb, but they're not bothered that much. And some other have neuropathic pain, and it's terrible. So onset is different depending whether it bothers you or not.
Thanks for clarifying that. We have a question from an attendee whose husband has been posthumously diagnosed with CANVAS. Her sister-in-law has CANVAS, and she's looking into this for her children. You say that sensory conduction studies show vestibular impairment earlier than other tests. How soon can children have this study or this testing done?
Yeah, so basically, if I understand it correctly, the patient diagnosed with this disease is asking about risk for children and when should the children be tested.
Mm-hmm. Broadly speaking,
Okay.
yes.
If that is the understanding of the question, what I would say is that, and what I tell patients in clinic is that the risk for the children to also develop the same disease in nears zero. Is not zero. 0 and 100 in medicine are, are two numbers that we don't like to use. It's because very rarely 0 or 100%. Okay, the chances are very low. There would be a risk in the case because all of the children of a patient with biallelic expansion will have one expanded allele. Okay, but we also know that 1 out of 10 people around the world have the expanded allele. So that's not enough to start investigation, testing, or anything. I would just say that if, and there's been on top of my mind now, maybe 10 families where children have developed a similar phenotype. So that's if there are signs and symptoms, they should be investigated as anyone else, bearing in mind that direct transmission is unusual, but it's possible that the partner is one of that 10 people around, which has also the expanded allele. And then there's 1 out of 2 chances because you have 2 chromosomes, they pass it. So it's low. We're speaking of something around, 5%. But I wouldn't recommend starting any test, particularly when they're young. And if when they're 30, 40, they start developing, sensory loss or chronic cough, we should keep an open mind that although it's rare, there are some cases, but the general rule of thumb is you've been diagnosed with a recessive disease. At worst, your brothers and sisters, siblings are at risk. And in particular, they are at 25% risk of having the same. So 1 out of 4. But for your children, you should just reassure them. You should just say, it's unlikely will affect you. Okay, I think this is the message in terms of counseling patients diagnosed with the biallelic repeat expansion.
Thank you so much. And then we've had a few people ask a very similar question. Could you speak a bit about any potential biomarkers that have been identified for Canvas?
Yeah, so biomarker, it depends. If we're speaking of biomarker, because when Canvas was a syndrome, okay, then the gene itself is the biomarker. So it tells us it's a genetic disease. So the first thing is to confirm this is a genetic disease. So it's not just an exercise of style. We need to know. And ideally, we would like, although this is not feasible in everyone today, to know the repeat size for the reason that I told you. So a biomarker, in a way, predicting how the disease is going to progress is the repeat size. So this should be done as a collaborative study, and we plan it as part of our genetic modifier study, but it's a big task. So that would be a biomarker. Now, in terms of the typical wet lab biomarker in serum, we did run a study, and I'm sorry I didn't include that, but we did look at a particular protein which leaks from the nerve as well as the central nervous system, which is called neurofilament. Is a very stable protein. It's been looked across a range of neurological diseases. It's been shown to be responsive in a way to progression. So we saw that patients with advanced disease have higher level compared to people with more in the early stages of the disease. So that is something useful, but we haven't been able to do it prospectively. So to say, oh, I measure it like today, and I measure it again in 1 year. Has there been any change? Would this be a possible outcome measure for trials? We don't know yet. But yes, I think wet lab biomarker are promising. And the other biomarker would be MRI. We've looked at brain MRI, and these also can help us and to measure the disease progression, because I must be honest, sometimes the neurologic examination has some limitation. The bedside neurologic examination is informative to diagnose the disease, but we struggle to see a change over a year, which is good because I see patient after a year and I reassure them. I'm saying, I haven't seen any change. Obviously, probably if I see them after 10 years time, something will have changed. Now, 10 years is not enough for a trial. It's too long for a trial. So we desperately need a responsive, reliable outcome measure, which will come probably from investigation or a very thorough neurologic assessment. And this is really what we want to do with this international natural history study, which has also the support of the CRC-SCA and NAF. And it's really something that we would love to see patients, keen on and engaged. So MRI, and personally, I think vestibular testing would be good because it's really precise. It's not available everywhere, but it's a quite accurate testing. While sensory action potentials, nerve conduction studies are always completely gone. And if something is gone in zero, there's no way to measure progression from zero. It will stay zero.
Well, it's good to know that this work is ongoing and more is being learned every day. Our
Yeah.
next question is, do we have an idea of the frequency of non-expansion mutations that have been found in RFC1 ataxia patients, such as patients with a point mutation on one allele and an expansion on the other allele?
Yeah. Yeah, I don't want to give an exact number, but I would say that it's probably across our cohort, it would be probably something around 1%. I would say probably 1% is quite small. It's 1%. And if we consider the unusual configuration, the one that require extra work, maybe long read sequencing, maybe another 1%. So I think really most patients have the typical biallelic repeat expansion. It's similar to Friedreich ataxia, although in Friedreich ataxia, I think the point mutation are a little bit more common. Here, they're so far still observed, but not super common.
And then we have another clarification question. So you mentioned earlier onset versus older onset. Could you provide some age ranges that correspond to these groupings?
Yeah. Again, speaking of cough, the cough can be present as early as the second decade of life. So some people start coughing as teenagers, more commonly in their 20s and 30s. Okay. Some patients start coughing or notice that they start coughing later on, 40, 50, 60. Okay. And in some of them, it's just minimal. Okay. So there's a range of variability. When it comes to, the neurological symptoms, I would say that, the earliest onset of, neuropathy and ataxia, I would say it is someone in their 30s. Okay. I would say that, people coming to medical attention before the age of 30 for a neuropathy or ataxia would be unusual, would be more common when they're 40, and it would peak at 50, 60, right? That's my understanding on top of my mind, like a breakdown that I have in my mind. But that doesn't mean that I think things are already happening. I think in someone probably in their 20s, early 30s, it might be that particularly the sensory neurons are being lost very slowly. They may not notice anything, they may compensate, they may still have a good balance, but if they push themselves a lot, or if we do like nerve conduction studies, we see that there is a reduction of the sensory action potential, and with some abnormalities at the examination. And a story regarding this, when I was still in Pavia only at that time, and as part of workplace surveillance, I was referred a patient that the doctor has found he had no reflexes. Okay. No reflexes is unusual, but he was absolutely fine. He was a driver, no reflexes. So those ones that we test with the hammer, the usual hammer for the neurologist. And so I did the nerve conduction studies, and he had no sensory action potential, but he had no symptoms whatsoever. Now, a few years later, we did discover the disease in, scientifically. And then I thought about it and I said, what about if he has it? And I tested him and he was positive. So basically, he had no symptoms. He had just an abnormality at nerve conduction studies, and it was just an early sign of something that would have become symptomatic probably 10, 20 years later. And that's why we want to identify this patient with sensory neuropathies when it's just a sensory neuropathy. And we're also testing patients just with cough, with the cough clinic, because obviously in neurology and in neurodegeneration, it's hard when it comes to treatment to, build back our neuron. But what we can, try to do is to prevent them from dying. So that will be very important to identify cases early, because whenever we'll have any effective treatment, and we all hope soon, although there's still a lot to do, but those will be the ones that probably will benefit more.
And then our next question is, why does southern blotting need to be used to test for RFC1 mutations? Why
Yeah.
can't something like PCR be used to detect the repeat length?
Yeah, the problem is that the PCR is good to have an idea that the repeat expansion is there, but it's not enough to confirm it for a simple technical reason. This repeat is very big, it's massive, and there's a lot of C's and G's in it. Now, the PCR is basically, something which transcribes your DNA, okay, like it replicates the filament, and then you get many of them, and then you see it, right? And if you have something which is a few hundred nucleotides, is fine, but in this case, it's usually 5,000 nucleotides. So this is too big, and also the polymerase doesn't like the C's and G's, so it falls off, and basically you don't get any PCR product. So that's why if you want to see and measure the presence, you need something which is not, it doesn't amplify the repeat, doesn't need to read the repeat. You just cut it on the two sides, and then you separate it, you run it, and in some way you stain it. So you cannot interact with the repeat through the PCR. You need to just cut it and then look at it. And long-read sequencing, optical genome mapping, and Southern blotting are the three techniques. And we've been using optical genome mapping. Again, this is quite technical. It's good. It works well, and is a little bit more, novel technology which could be implemented in the future.
And the complexity of the sequencing, is that why it's been difficult to access this test around the world? How common is it for people to have these technologies?
Yeah, I think the test is difficult because you have to, perform multiple PCRs. You have to optimize them, and you have to interpret them. And the interpretation is not always straightforward. So I think there's been, some centers have been lagging behind on this, although everyone is very motivated to have this in place. But it would be ideal to have a good new technology which fits for all. And I think that, they're doing great advances from the long-read sequencing perspective. You could take many repeat expansion at the same time, have an accurate information about sizing, content, because you also want to know the sequence. So that might be a way forward. But in general, as said, it gets quite technical, but we're very happy to work with clinicians and patients that struggle to achieve a diagnosis to kind of address them, and if needed, do some wet lab work ourselves if needed.
Yeah, and then one final question, because I am aware that we are at time. We've had a number of people ask how they can get more involved with research on Canvas. Would it be all right if they reach out to you? I know NAF, as studies become available, we will be putting that information out there on our research participation page. But how can folks get more involved?
I think that's an excellent question. And, initially there was a Facebook group. So I was addressing people to this Facebook group. It's always nice to talk to other people with the same condition. But I think now really, National Ataxia Foundation in the US and internationally, and other Ataxia Foundation like Ataxia UK, they are, becoming more aware. they get to know the condition. And I think I would recommend patients to reach out to them. And I really, I receive an email from patients all the time, and I try to keep up with these emails and respond as much as possible if they want to be, if they have specific question. But I would say that probably you would be the right initial point of contact, and we will make, advertise those studies, and clinicians who see patients will be aware of these ongoing studies.
Well, thank you so much, Dr. Cortese, for sharing your time, your insight, and chatting with us today, and for answering all of those questions. We really appreciate it.
Thank you so much. Thank you to everyone in line. I saw also some colleagues and collaborators from Miami and University of Michigan, which are also involved. And so it's an opportunity to say hi to them. So there's really many good people around that now are, devoting their time to this disease. So I hope we'll soon see advancement also in terms of treatment for patients.
And thanks for everyone who was attending today. I hope you found the session valuable and you learned something new. And wherever you are in the world, good morning, good afternoon, good evening. Hope you have a wonderful day ahead. Take care, folks.